My name is Swapnil Hiremath from Ottawa, Canada. I'm a nephrologist and epidemiologist at the University of Ottawa.
Hello, my name is Danielle Belardo. I'm a cardiologist in Newport Beach, California, in private practice. I'm the chair of the nutrition committee for the American Society for Preventive Cardiology, and I'm on the American College of Cardiology Nutrition Subcommittee.
Many of our patients do not have access, as you mentioned, to go to a grocery, right? They're relying on processed food or canned food. However, these options are rich in sodium, they're poor in potassium and other healthier minerals. This access to a dietitian or access to an advice is an issue. How can we tackle this?
It's a complete, very unmet need, especially because physicians do not certainly generally have the time to do the great work that a dietitian can do with the patient, and we're not trained to do that kind of work as well. Unfortunately, the coverage currently for medical nutrition therapy in the U.S. is spotty. With regards to commercial insurance, certain commercial insurances will cover medical nutrition therapy for various different comorbidities, but many won't, and that's just hit or miss. Medicare at this time, Part B, will cover a visit with a registered dietitian for medical nutrition therapy when referred by a physician, but only if the patient has CKD or diabetes. But I find that oftentimes one thing that's simple that can help is sometimes we overcomplicate as well the nutrition advice and try to be too prescriptive. And I think that if we are just making recommendations that are small and general to our patients, they can sometimes grab onto it a little more. Meaning, if you encourage patients to focus eating basic things like more fruits, vegetables, whole grains, legumes, nuts, and seeds, and these foods are naturally lower in sodium, they're naturally higher in potassium, and they're naturally higher in fiber because dietary fiber only exists in plants. So making these recommendations covers all of the class 1 recommendations from the ACC guidelines without even having to have the patient take out a checklist and say, okay, this many grams of fiber a day. Sometimes it can be helpful to just give them a more overarching dietary pattern, small changes that are sustainable for the patient, and important things. Of course, knowing where socioeconomic status, where you're working, and food security and issues like that are important. Reminding patients that things like frozen fruits and vegetables have the exact, if not more, nutrient value than fresh fruits and vegetables. Knowing that there's no hard outcomes that show there's any difference in organic versus conventional produce. Glyphosate is not dangerous. Things that fearmonger people away from fruits and vegetables that make access even more difficult. So simplifying it for certain patients, knowing your patient population and knowing how much details they need. But you can sometimes, by just giving them an overall recommendation of a shift of a dietary pattern, you can really hit all of those ACC AHA Class 1 recommendations without even using those specific words or terminology and giving them too much to figure out.